You're very welcome to our XR for Rehab webinar series. My name is Dr. Joe McVeigh. I'm Head of Physiotherapy at University College Cork in Ireland, and I'm also a member of the XR for Rehab Collaboration and Innovation Network. So you're very welcome. And I'm delighted to introduce our speaker today, Dr. Amy Webster. Dr. Webster has a background in neuroscience and medical visualization, and has just recently completed her PhD at Glasgow Caledonia University in collaboration with the Glasgow School of Art. And her PhD was funded by the MS Society in the UK. So Amy's PhD investigated upper limb rehabilitation using immersive virtual reality for people with multiple sclerosis, and she's going to be presenting her findings today. So absolutely delighted. You're very, very welcome, Amy, and thank you for your presentation. I'm looking forward to it. The presentation will be recorded, and please use the Q&A function or the chat function to put in any questions, and there will be the opportunity for discussion at the end of the Q&A. Okay, so I'll pass over to Amy. Thanks a million.
Thank you, Joe. Thank you so much for inviting me to talk here today. Exactly what Joe was saying, I'm going to be talking about my PhD, as it's been my life for the past few years. Let me just share my presentation real quick, and then I'll go back to talking about presentation. Right, so I'm just sharing my screen now. So hopefully you should be able to see those slides. Any issues, please do let one of the team know. So yeah, exactly that. I'm going to talk about my PhD with a focus on the co-production study that took part. That was sort of the foundational work when it came to creating immersive virtual reality-based games for people with MS or multiple sclerosis for the purposes of their upper limb rehabilitation. So I think it's important to talk about a little bit about what multiple sclerosis is, as I'm sure there'll be different backgrounds, different disciplines, and it also might give you some context as to the development decisions made later on and some of the findings as well. So what is it? It's a chronic inflammatory demyelination disorder of the central nervous system. So the myelin, that protective sheath around the nerves, becomes damaged due to inflammation in the brain. And when there's damage to that myelination, there's a whole sort of cascade of different symptoms and disability. And it's quite prevalent within the world. It's probably a bit higher now, but 2.8 million worldwide, and over 150,000 people in the UK are diagnosed with multiple sclerosis. But with a particularly high prevalence in Scotland, I think there's over 17,000, I believe, of people with the condition. And Scotland's quite it's a wee small country, so that I think that's roughly 1 in 300 people affected. And MS is a very complex but very unpredictable condition. So there's sort of no really way of predicting what will happen, but there are 3 typical subtypes of the sort of the how the disease presents itself. So most people are initially diagnosed with relapse and remitting MS, that's sort of periods of stability, and then sort of unexplained worsening of symptoms. That's what we call a relapse, or lesions present. So that lesions are this sort of demyelination presenting within the brain. So there's sort of ongoing periods of stability and worsening. Typically people recover from these relapses either partially or completely. And then people with relapsing and remitting MS move on to secondary progressive. So rather than this recovery, there's now ongoing progression of disability. And then primary progressive is this sort of progression of disability that's present from the onset of diagnosis. So I've said, I'm going to say again, MS is very complicated, very variable. There's so many different symptoms, degrees of disability, but these symptoms can be grouped into motor, sensory, cognitive dysfunction. So motor can be anything from loss of the ability to walk, gait stability, posture, spasticity, sort of unexplained contortion or constriction of muscles, but also problems with the upper limb as well, dexterity issues. And that can also be seen within sensory, so things like numbness anywhere in the body, tingling, sort of aversion to heat. So many different variable sensory dysfunction as well as motor, but also cognitive issues with memory retention, learning, things like that. And it's quite typical within MS for, as I mentioned before, people, there'll always be some sort of degree of progression of disability or this worsening of symptoms. And because upper limb is my focus, I thought I'd just like to highlight that roughly over 75% of people with MS have some form of upper limb dysfunction, and that can be present in the early stages of diagnosis. It could be anything from sensory, but also motor dysfunction as well. And unfortunately, there is no cure for multiple sclerosis. There's been big advancements within the treatment or the pharmacological treatment with disease-modifying therapy. So that's a way to slow down that progression, reduce the attacks I mentioned earlier. And most people with MS take some sort of symptom management medication. So pain is another really big problem within MS. So pain medication, help with bowel and bladder dysfunction, a whole different array of different symptom management they could be taking. But unfortunately, there's no intervention pharmaceutical, no medication, no magic pill that will help restore or manage motor dysfunction within people with MS. So the standard treatment is rehabilitation. So this sort of overall strategy of improving mobility for people with MS or any condition or injury. And that's typically tailored physiotherapy or exercise. And we know from the literature that it's very effective for improving motor function. However, it's less so evident within upper limb because it's been typically neglected within MS research. Walking and gait is very crucial for people with MS. It's how we navigate the world. But upper limb dysfunction is just as impactful. We use our upper limbs, our arms, our hands for interacting with the world as well. We need them for activities of daily living. So it's really important that we have effective rehabilitation strategies for people with MS. But there are specific challenges when it comes to rehabilitation and physio and exercise within MS. It's a lifelong chronic condition. Think about all the different symptoms I mentioned earlier that can affect people's ability to travel to such facilities. Their symptoms might interfere with their exercise, or their symptoms might become worse after exercise. There's lots of different things to consider. So it's a lifelong commitment, it's a lifelong treatment. And the key with physiotherapy or rehabilitation is a sort of repetition, getting people to do certain actions again and again, and asking someone to do something again and again for the rest of their life. That is a chore. It's quite hard to be motivated to continue to exercise and engage within physiotherapy or rehabilitation. So it's a massive demand for the person involved. So that's kind of where this sort of research challenge is that there's a lack of upper limb rehabilitation evidence, but we know it's really important. And then we have on this other side that while it's really important and we should be encouraging people with MS to do it, it's very hard for people with MS to engage with it, that sort of exercise long term, because it's boring, it's a chore. So that's exactly where virtual reality comes in. I'm not too sure if I need to sell it too much to this type of audience, but virtual reality has unlimited potential in the virtual worlds we can create, but also it's really engaging, really motivating. And virtual reality can sort of be used alongside series-based games or exercise-based games or any sort of game to create an experience beyond traditional exercise. And as part of my PhD, I conducted a systematic review investigating virtual reality-based interventions for upper limb rehabilitation in MS. And there is some preliminary evidence to suggest that it could be effective, but a lot of the papers have quite small sample sizes, conflicting protocols, different technology used that was used a while ago, a little bit outdated. But why virtual reality? Why not just technology? Or why immersive virtual reality? Well, we've seen some preliminary evidence in some other demographics, so the general population or even stroke, that immersive virtual reality in particular compared to non-immersive systems, so the use of headsets, hardware and software to sort of create this feeling of immersion or sense of presence as well within the user. And that actually is quite beneficial when it comes to rehabilitation and also physical engagement, sort of a reduction of cognitive load. And there's some evidence to suggest that visualization of movement can be quite beneficial when it comes to relearning function. So again, what's this challenge here? As I mentioned earlier, there's some inconsistent protocols. And when I started this PhD, there were no papers looking at immersive virtual reality, despite sort of the benefits that were emerging when I first started. But these papers were focused on stroke. So it really seemed like a great research gap for me to look into was immersive virtual reality, in particular for people with MS. So at the start, I was thinking about, okay, so immersive virtual reality is really beneficial. What games can we use alongside it to help promote physical activity or upper limb rehabilitation? So this sort of debate between like bespoke and commercial games was something I looked into. So bespoke, something that's been specifically developed for purpose, and commercial is, you know, a game designed, developed for the basis of being commercial, selling to a general audience. And within MS, there's kind of a mixture between the technology used. Sometimes there's a combination with virtual reality setups, but also the use of robotics and functional electrical simulation, and some commercially available consoles, so Nintendo Wii, Microsoft Kinect. And also, as on top of that, there's a mixture of this bespoke versus commercial games that are actually used within the intervention. It's kind of a question of what do we use? Do we use something that's already on sale, or do we develop something for purpose? And there's, I guess, good evidence for both. Commercial-based games have a lot potential for effectiveness within multiple demographics, different groups. It was actually a really interesting study that was looking at serious games, so games developed for purpose, versus commercial-based games using the Nintendo Wii. And although the group that were using the Nintendo Wii didn't have any statistical improvements within upper limb function, they had an overall higher perceived health score. So there was something about the commercial-based games that were still beneficial that, you know, made them feel like their health was improving, or there's some sort of benefit to them, even if that wasn't displayed within the upper limb outcome measures. But on the flip side, on the other side, there is kind of this growing concern, or established concern, I should say, that these commercial-based games are not suitable for people with reduced mobility or MS. A few studies looking at the Nintendo Wii, for example, that was the hit trend all those years ago within rehab. But lots of concern about the usability, the appropriateness of the exercises, the way that the systems would feed back the progress. I don't know if any of you ever played the Nintendo Wii or the Wii Sports, but it was quite humiliating at times. If you didn't get a good score, the system kind of punished you for it. And people with MS or anyone with sort of reduced mobility, they'll have days where they'll struggle, or they won't be able to perform as well as they could. So there's kind of this idea that if we develop games that are sort of fit for the person in mind, they'll be more received better, but also more beneficial in the long run for people with MS. And that kind of ties into the framework that I use. So I use the Medical Research Council. So that's the UK's big organization, research organization. So that was the sort of first stage, was this sort of identifying and developing. So I thought, well, there wasn't really a strong indicator of a game or a system I should use, so I should develop my own. And sort of core elements to consider as well is, you know, this engaging stakeholders, or these end users within this within the process. So when it came to the development of my games, immediately what came to mind was user-centered design. So having the user at the forefront of your development. And sort of continuing on from that, I know co-production is so massive now. It really is the new in-trend thing about how we involve people in this development of interventions or products throughout the whole development process in the sort of goal to create a better suited product. If you have people with the lived condition or the experience throughout each individual stage, or as many stages as you can, you hope to create a better, more suitable product. And that's exactly where co-production shines. But I found it really hard to navigate all the different terms. There wasn't really any established frameworks when it came to the engagement of the end users. So, you know, or what methods I should use as well for developing these games. How do I collect the data? There's things like co-design, co-production, co-creation, and all those different terms I've quite struggled to separate and wasn't too sure what term to use. Basically, no one really has well established, you know, what the distinct differences are. But for me, I see co-production as an umbrella term, which I've read in some other literature. And there's different degrees of stakeholder involvement. So without, I think co-creation has quite high stakeholder engagement and co-production is slightly less. So without burdening the people with MS too much, I went for the co-production approach. But also, in my mindset, it wasn't just about creating the virtual reality-based games. It was about the production of the intervention overall. So not just wanting to know about virtual reality and the games that we can make and create, but how it should be delivered and developed and implemented as well. So that's why I went with a co-production approach. So sort of the big part of my PhD was the pre-development focus group study. So the aim was to develop a comprehensive set of requirements for these VR rehabilitation games that I sort of mentioned earlier, with the aim of improving upper limb function for people with MS. So this idea that if we make something for people with MS, we should involve people with MS as well. But it wasn't just people with MS I wanted to have input from. I also asked people had expertise in physiotherapy, so clinicians as well, to take part. And this sort of set of requirements is basically just a list of functionality that will help my software development. So basically how the games or the system should operate. So how does it work essentially? But this was during COVID lockdown. So I went for online focus groups. I had four in total, 2 per group. So 2 focus groups with people with MS and then 2 with clinicians. And essentially, I wanted to gather as much information as I could to help design and develop these games, but also think about the implementation or kind of next steps going forward. So there's also a lack of qualitative data when it comes to virtual reality or rehabilitation in general for people with MS. So I wanted to get their views, as well as the clinicians' views about virtual reality as an approach for upper limb rehabilitation, get a sense of what upper limb problems they find particularly difficult, what current methods have been used by the clinicians as well, and also different sort of integrating factors, so motivations in exercise, challenges of exercise, but also what would you like to see in these games? So basically, what would you want us to consider or design these rehabilitation-based games? So give us some recommendations for the development. And this paper has been published shameless plug, but if you'd like to read up on it further as well. But I'll go through it as well here today. So I recruited people online. This was the age of lockdown. So different research networks. So the MS Society have a research network. And also there were some people that agreed to take part, but they also said, I know someone with MS who might be interested. So that sort of chain referral sampling as well. For the therapists, thankfully I have a network of peers, well, my supervisors do, of their connections with the different physiotherapists across the UK and Ireland. But I also use the Therapist in MS research network as well. Again, all online, all advertised online, and quite small eligibility criteria. For people with MS, you have to be an adult with MS, some degree of upper limb dysfunction, and the ability to use video conference software. So we use Zoom for people with MS and Teams for the clinicians, because that's what they use, as many of them will be within the within the NHS. So clinicians, they only had to have any level of experience when it came to delivering MS rehabilitation, and they could be from any sector, so third sector or NHS as well. So the difficulty with online focus groups when you're trying to convey virtual reality is no one gets to try out virtual reality. So that was a big challenge for me. So a way around that was to sort of give contextualization, I guess, to virtual reality as an approach. We're able to show them some of my previous work with my master's. So this image here. So this is the Leap Motion device, so a hand tracking device I developed alongside people with MS as well. This is a non-immersive virtual reality based approach. And these two here are the immersive virtual reality approaches. So this is the Oculus Rift with the Leap Motion attached. And this one here is a student project I was involved with, the Oculus Quest 1. I know it's now called the Meta Quest, but I will stick to using the Oculus Quest for this presentation. So yeah, so sort of giving them an idea of different technology we can use, but also different hand movements we can facilitate, we can replicate, and what games have we tried out before as well? So what games have we used in research before? And the way so after I conducted these focus groups, I had the transcripts recorded. I used theme-based content analysis, which is just basically a modified version of content analysis where you group the responses based on the content, the language of the response. And you group it based on theme. So that's why it's called theme-based content analysis. And I thought it would be quite useful to sort of show you what it sort of looks like. So it's very similar to traditional qualitative analysis. You assign themes, and then you group them all together. So this is, and it's presented in a much bigger table. So you're sort of able to, because you're quantifying them, able to identify trends. You know, it gave me some quite good justification if there was lots of responses within a particular topic or theme or category. That would help my justification when it came to the development of the game. So that's why I went with a sort of quantitative approach as well as qualitative. Oh, sorry, wrong one. Yep, so who took part? So 10 people with MS took part, 7 females, 3 males. MS is predominantly more frequent within females, and a good variation of different MS types and different times of time since diagnosis. So how long have they been diagnosed with MS? And we had a good variety as well of ages as well, ranging from 26 to 80, which is great. I love that diversity. So the mean age was around 54 years old. And then for the clinicians, all female, not necessarily that surprising. It's quite a female-dominated area when it comes to rehabilitation. Good length of experience, very they know what they're talking about. Lots of experience here. So there were 5 physios, 2 occupational therapists, and 1 MS specialist nurse, which was great to see some diversity in specialties. 6 worked in the NHS and 2 were in different settings. I believe third sector, so a charity, and then also within a academic setting. So what were the findings? What did I find out? So sort of based on these themes, I grouped them into sort of themes, and these are sort of the overarching themes. So the impact of MS. So what I found was that people with MS, because of their upper limb dysfunction, has negatively impacted their activities of daily living. So things like dressing, grooming, eating, but it's not just, you know, the upper limb dysfunction or the mobility, it's also associated symptoms. So things like fatigue are really quite negative influence when it came to performing and these activities of daily living and sort of what negatively impacted their quality of life. And dexterity issues in particular were very common. So, think about that sort of fine motor movement in the hands. And because of this loss of upper limb function, a lot of them lost what was meaningful to them when it came to their hobbies. So things like dressmaking, writing, playing the piano. Because of this dysfunction, they were unable to continue on their passion. So some had, were obviously quite upset about this, but some of them have sort of come to terms with that's just the nature of MS as well. And what was quite interesting, that although a lot of them noticed that, they've got upper limb dysfunction, it wasn't so much about improving the function, but it was adapting to their dysfunction. So using additional support aids or basically doing things differently rather than to regain the function. And something else that came up quite a lot was this variable nature of MS. So not just between person to person, but a person's condition for themselves. So each day is different, good days, bad days. So that variable nature of MS came up a lot. When it came to their exercise, there was sort of a quite important finding, good justification for my work, that there was a lack of upper limb exercise or rehabilitation. A lot of them had never undergone any physiotherapy for their upper limb, and many more did not engage in any upper limb exercise. If they did, there were things like weights, balls, that sort of thing. And what was really important to them, rather than, I guess, improvement, was this maintenance, this sort of use it or lose it attitude, which I think is really important with MS when you've got that sort of chronic long-term disability. Maintenance is really important. And there were conflicting views or opinions of the exercise. Some enjoyed it, some found it meaningful. They were determined to do exercise. They liked having it, they liked being in control. But some others, and I don't blame them, found it a chore and boring, just something that they just didn't have the time to do, or no, I guess, motivation to do. And some of these barriers and adverse events could also impact their ability to exercise. So barriers could be anything from personal, so not having the space to exercise in their home. I think this was sort of prevalent because it was during lockdown. We're just in our house. We realized how small our houses were, how COVID shut down some of the services, some of the MS centres in their local area. So things like travel as well. And some of them had particularly were kind of worried about their symptoms during exercise, although it's really beneficial. It's also really tiring for them as well. So there's this sort of additional need to plan around exercise when you've got MS. And it's a shame because these MS centres and this access as well can be a facilitator. Having healthcare professionals, whether it's a personal trainer or physiotherapists, is really motivational and beneficial for people with MS to engage in their exercise. And they also found that socializing was really important. It's a lot easier to go with a friend than to go alone. You've got someone else there to back you up, or it makes it a little bit more enjoyable of an experience for some, which is really interesting. So what did they think about virtual reality? Well, the initial response was really positive. They saw a lot of good potential. Obviously, it was during lockdown, but they saw a lot of potential within the home use. It solved some of those barriers I mentioned earlier with travel, space. They believed it could be really meaningful. They really felt it could be beneficial when it came to improving their upper limb function. They saw the benefit of it during those videos, that they saw those repetitions, those movements, that encouragement of movement would be really beneficial. And it just looked fun as well. So positive initial reactions. And when it came to looking at the different VR technology, there was the Oculus Quest, which is a wireless headset. There's no need for a computer setup. They really liked that element of convenience. So convenience was something that came up a lot, which is not surprising. We like convenience in our life. So some of the sort of negative aspects of it, or sort of the negative use of VR, was hypersickness came up a lot. Sort of it makes sense because people with MS can sometimes have balance issues, motion sickness, things like that. So that wasn't too surprising of a result. That was their main concern. But also some discomfort concerns. So, will the headset be too heavy? Will I be able to get it on? That sort of discomfort when it came to actually using or wearing a headset. But also disengagement. How long will I use it realistically? It's quite cool, it's quite novel, but will I still want to play it in a month's time? So disengagement came up quite frequently as well as a sort of concern. But ultimately, they were all very open to trying the VR. They stated that supervision was important. Also, I think kind of an important thing to bring up was some saw the benefit for motor rehabilitation, but there was one gentleman who mentioned they didn't think it would be suitable for them because their problems were sensory, which I think is important to note. So what did they recommend for development? Well, it's no surprise, but they said, please be mindful of people with MS, the target audience. You need to be careful with when it comes to feedback. Things like your score, have you done better than last time? You need to be careful when it comes to such a variable disease or condition. So think about how you'll be able to store these results. Will a timer be too stressful? Things like that. Am I able to sort of delete my progress and start fresh when, if I've had a relapse, for example? But so that was a really good thing to keep in the back of my mind. But on the other hand, they really liked the idea of tracking progress. You need to know how you're doing, I think, for your own sake. Are you able to sort of change your goals, progress moving forward? And this sort of score, these elements tie into competition, this sort of the self-competition, doing better than last. That's really useful for keeping people motivated. They also wanted to know what games specifically will be doing. So what are they targeting? What upper limb movement am I trying to improve here as well? When it came to sort of the suggestions for the games, there was sort of came up a lot with a sort of end result, sort of multi-purpose. So rather than just saying I've done a game, there's been an additional element to the game. So have I learned a new skill, for example, such as playing the piano? Have I created something? Have I solved the puzzle? Have I learned something? So this sort of additional element to just I've played a game for X amount of seconds or X amount of minutes. There's an additional component to it that's not just doing exercise. There's something there else that can also be sort of hidden or disguised as well. But also they mentioned that it was quite good to have continuous ongoing development. So people trying out these games and then feeding back, and that sort of co-production-esque method of continuous feedback to improve upon the games. When it came to, I guess, the game activities, there was a sort of I asked the question about would you prefer real life-based activities, or would you like something a little bit more abstract? And people with MS leaned towards a little bit more abstract because they thought it might be a little bit more fun, but they were open to the idea of having variety. When it came to the sort of targets they wanted to focus on, strength came up a lot to improve their strength, and maybe even think about the haptic. Is there a way that we can implement haptic feedback, which I'm sure some of you might know is quite challenging within VR and game consoles in general. We're quite limited in what we can give back to people. And so the last sort of thing here was the importance of choice came up. They really wanted a variety of upper limb targets. They don't want the games all to be doing the same thing, a bit of variety. So with the targets, the games themselves, but also difficulty, that sort of ties into being mindful of the target audience. People have days where they feel, I guess, better than others, but also people with MS will vary as well of their ability. So difficulty levels came up as something to implement. So what about the clinicians? So their current methods and challenges. So very much thinking about the upper limb rehabilitation as a systematic approach. So thinking about the whole upper limb, but also considering core stability as well, which is sometimes neglected within MS. is sometimes neglected within rehabilitation, and keeping the tasks really functional and thinking about strength as well. There were some challenges both with the service and patients. So the NHS in particular is quite a strained resource at the moment. It sure was back then, but also people with MS, they have difficulty with, I guess, remembering certain tasks, the adherence, the motivation as well for them to do their rehabilitation. And that ties into them talking about the challenges within upper limb rehabilitation in particular. They said it was quite difficult to find engaging upper limb rehab strategies. The things they used, like therapy, therabands, were quite boring and childlike. And they also recommended socializing and exercise as well. So their views on virtual reality were quite similar. They saw a solution to the challenges. So they hoped it would be a reduction on service demand, something people can do at home. And they also liked the idea of visualization within virtual reality. They liked the virtual reality-based properties that not necessarily seen in conventional therapy. So things like escapism, visualization of movement as well. But they shared similar negative views or concerns. So disengagement was the most frequently mentioned concern, cyber sickness and safety, but also validity concerns. So is virtual reality going to improve their upper limb function or not? And that sort of tied into, they wanted to know about what research was currently available and why in particular VR should we look at? What is the special benefit of virtual reality for rehabilitation? When it came to their recommendations of development, they emphasized it should be meaningful for the patients, and also think about how we communicate or feedback the progress between clinician and the patient. But in terms of feedback, people with MS were a little bit more focused on score and time, whereas the clinicians really want to know about the quality of movement rather than the score, which I think is a really good point, unless the score indicates quality of movement. And their suggestions were very directly related to activities of daily living. So things like cutting vegetables, shopping, things like that. But also hobbies that people with MS have previously lost as well. They thought might be an interesting idea to implement. And also some of their suggestions, sort of the responses tied into this importance of choice, making sure that we are able to offer different technology for people with MS who want to use this. And they saw the benefit of virtual reality at home. They saw some benefits for clinics, but perhaps third sector clinics. And their challenge here was thinking about funding and not increasing the demand on services as well. And to think about how, if we're able to implement it, how are we able to make VR more accessible for people with MS, but also those living within digital poverty. There's also some of the responses related to finding specifically who would be interested with playing virtual reality as a way to improve their arm function. And also there were some age concerns, which are quite interesting. The clinicians in particular thought that there would be this sort of dislike, I think, with virtual reality or even just technology. So they sort of had that as a concern, that think about the age. So when we're comparing these groups, there's very similar positive and negative views, shared similar concerns about virtual reality, so cyber sickness, disengagement. Both groups saw it as a potential solution to the challenges, so accessibility, home use, reduce the service of demand. But there was different suggestions for the game activities, which was really interesting. The clinicians wanted to have games directly related to activities of daily living, whereas people with MS did not find that appealing as much. They found, when I suggested the kitchen, they were like, well, that's boring. So it's really interesting to see the different suggestions as well. When it came to hobbies, people with MS have already, I guess, had that milestone in their life. They've already achieved that hobby, and it might be quite difficult for them to go back and do a VR-based approach of their previous hobbies that they've lost. And like I mentioned earlier, there are different feedback suggestions as well. So that sort of ties into my general recommendations, making sure that there's customization for people with MS or anyone playing these different games to suit their preference, their ability, ensuring that we think about comfort to reduce cyber sickness as well, and keeping that sort of a lot of variety in the games and the people, the variety in the games, and think about the variety of ability within people with MS. Always being mindful of the condition, the target audience, and think about games that can sort of tie into that end result I talked about earlier as well. So how did I develop them? So using the sort of results from the focus groups, I created a table of requirements, basically describing the functionality of the system. And from there, I drafted some storyboards to send to the participants who took part in the focus groups. And there, that sort of helped my, I guess, my decision making about choosing which specific games to implement and design and develop as well. So that's the stage here. And then after that, I developed these games, and with some pilot testing, sort of go back to the co-production, that you have some feedback that will help refine the development of the games. So when it came to my storyboards, there were 10, I believe, games that I proposed, sort of asking them, what do you think about this? What feedback would you like to see? Would you play it? Would you find it useful? Would you recommend it to people with MS? Questions like that. And the software development that I used, I followed a rapid application development, so that sort of fast development of the game. So creating a prototype, not necessarily doing things systematically, basically prioritizing a fast development. Because in a PhD, you don't have a lot of time. But these are the sort of software, these are the software I use. So I use Unity to create the application, Blender for my 3D model creation as well. I use Procreate for the storyboards I showed you previously, and different graphics within the game. And I used Oculus Integration Software Development Kit for Unity. So that's how I was able to design these or develop these games for Oculus Quest. So these are the games that I developed. So piloted 3 games for the Oculus Quest 2 because people with MS like the convenience of this headset. So these are the 3 games that I designed. So Catch a Falling Star, a sort of grasp and release. Think about that sort of that fine motor skill I was talking about earlier. But also there's some elevation at the shoulder. And then there's the piano game, individual finger movements, ties into that end result I was mentioning previously. And then whack-a-mole. So this is the flexion, elbow flexion and extension, rotation at the shoulder. I think it's also quite good for the core stability as well, leaning over to hit these moles. For the first 2 games, there's hand tracking, and for the final game, whack-a-mole, I used there was a handhold controller to interact with the games. So I was able to implement a little bit of haptic feedback within that game. So developing these games, I'll just quickly touch on the feasibility study that I ran afterwards. So getting all that really great data from the focus groups and then developing these games, following that framework, I need to evaluate the feasibility. So I ran a feasibility trial. There was also a randomized control trial of an 8-week intervention of these co-produced virtual reality-based games. And there was 2 arms within the trial, so an intervention and a control group. So the intervention was 2 sessions a week for 30 minutes of exercise, and the control group were a usual care. So I had 2 different sites, NHS Lanarkshire and here at Glasgow Caledonian. And quite not too restrictive eligibility criteria. Needed to have confirmed diagnosis of MS, and any other significant conditions affecting the upper limb would be so things like a stroke or frozen shoulder. That would be reasons for exclusion. And any visual or cognitive problems that might affect people with MS actually physically using the headset that wouldn't be amended by glasses. So I guess not going into too much detail about this, but my recruitment aim was 30 people with MS. We recruited, I believe, 19. So the most sort of common reasons for not participating were feeling that the study was too much for them. I always heard, it's really interesting, but I don't have the time, or I'm not able to travel. I've got work. So, which isn't too surprising as well, but something to keep in mind. So, I had a good variety of different people with MS, lots of different MS types. This is just some of the demographic data. Again, I won't go into too much of the detail. So 19 participants were enrolled, 11 in the VR, and then 8 in the control group. So that's around 3.2 participants per month. There were 2 dropouts, both in the control and both unrelated to the study as well. I think also it's worth noting that only a couple of people with MS were currently undergoing any physiotherapy related to their upper limb. Some of these responses here is they were undergoing physiotherapy, but it was for their lower limbs. So really good adherence, really good session completion, 86.9%, which is really positive. And the most common reason for people missing a session or not taking part in that day were related to their MS symptoms in particular, which isn't too surprising. And a relatively low number of adverse events, things to do with pain, so arm pain, scapular pain, so that's shoulder blade, increased fatigue, and a controlled fall to the floor as well. So nothing too unexpected there. And really positively, there was no cyber sickness reported at all in any of the participants that took part in the VR group, which is really positive since that was such a massive concern in the focus groups. I also collected some upper limb outcome measures. I'm not too sure if that's of interest to anyone. Both objective and also patient-reported outcomes, so 9-hole peg test, action research arm test, hand grip strength test, Albahan questionnaire, so that's just basically asking how easy or difficult it is for people with MS to participate in activities of daily living, and also a spasticity questionnaire as well. And there were positive trends for improving outcomes within all of the outcomes, but in particular with the 9-hole peg test and the hand grip strength test in the intervention group. But we did observe a ceiling effect in the action research arm test. So this outcome measure probably won't be used in the future. Basically, what that means is participants that took part at their first session, a baseline, they were already scoring quite high. So I'm not too sure if we would use this outcome measure in the future. And a really good evaluation, good feedback of the games as well. So I used the use questionnaire and semi-structured interviews to sort of gather data, quantitative and qualitative, about their opinion of the games that I developed based on a focus group study. So there's a max score for each of these categories of 7, so really good scores overall, particularly with that sort of ease of learning. So people find it quite easy to learn how to use, which is really positive. And sort of general comments were they found it enjoyable and fun. In particular, high scores were really motivating for people. That was a big, I guess, positive attribute to these games. I also like the different difficulty levels, but there was a sort of the question of how do we progress these difficulty levels further? How do we progress this rehabilitation further on? And sort of negative sort of comments were about the piano being quite challenging, but also some usability issues with the headset, so things like weight, fogging off the glasses and things like that. But as technology advances, we hope the weight will be less in the future as well. So some really nice positive feedback from, these are some quotes from my interviews. Basically, just to touch on it quickly, people with MS really liked the atmosphere it provided. It was a nice distraction. It was something beyond traditional exercise. So that's really positive to see that they enjoyed the exercise, but it was virtual reality or in these atmospheres we could provide that sort of made it a really positive experience for them. And also, some people with MS found that there was a definite benefit, a self-reported benefit for taking part. So they reported some improvement in function, but also just finding it beneficial that they took part in exercise as well, which is really positive to hear. Some quick technical setups. If anyone's using Oculus Quest 2 or similar technology in the future, you've got the technical setup did vary. So you've got to load the application within the headset, set that safety boundary as well. That could take some time, and extra time at the start for people to get used to the headset and technology. And there were different, I guess, usability when it came to the Oculus interface. So when you put on the headset, before you load my games, you have to, the people with MS had to navigate the Oculus Quest interface. So some people found that a little bit tricky with the sort of pinch mechanism the Oculus Quest implements to sort of pick or load applications. Some people preferred the controllers as well. And when it came to sort of hand tracking issues, there wasn't too many, but there were some instances where sunlight, I know in Glasgow, sunlight was an issue, which was quite interesting. And there were certain situations where I wasn't able to change room, but that's something that can be easily amended in the future. But also hand tattoos got in the way of hand tracking as well. So that's something I solved by just having the participant use nitrile gloves as well. Because of the hand tattoos, they can affect the hand tracking of the hand within the Oculus Quest. So overall, very good feasibility and acceptability of these VR games that were designed for and by people with MS. Really encouraging to see the low adverse events. In future, I would recommend a seated gameplay. I think that might have helped the cyber sickness. I think it's just generally a good recommendation for VR. And I mentioned earlier that we didn't meet the recruitment strategy, so think about ways to improve these strategies in the future, get some patient and public involvement about how we can sort of raise awareness and recruit more people to research in the future. But also perhaps as well make research more accessible as well. So lots of different things I can do next. Refining these games. Should I find a target audience? There's some of these questions that were brought up in the focus groups by participants. They wanted to know about certain research, and there were some questions we just weren't able to answer because the research wasn't there when it came to VR in MS. So perhaps look at brain activity, and then following the framework, think about effectiveness and cost effectiveness of this approach, but also think about long term. That sort of ties into the disengagement concern, and there's a lot of rehabilitation data out there, but when it comes to long term, that's neglected. And think about implementation. I was talking about earlier about making VR more accessible. Is this something we can bring to people at home? So many people I want to thank, just really quickly, my supervisors at Glasgow Caledonian, as well as Glasgow School of Art, every wonderful person who took part in the research. It's definitely not possible without the people that dedicate their time taking part in the research, as well as my wonderful funders, the MS Society, and the teams that helped me with my feasibility trial in particular. These are my references. Pause if you want to read the recording later. And then further reading if you're just that keen and you want to know a little bit more about the topic. Thank you so much. Sorry that was a bit of a ramble, and happy to hear any questions you may have.
That was excellent, Amy. Thank you so much indeed. It was really, really impressive, the extent to which you took the findings from your qualitative work and incorporated that into the development of the games and so on and so forth. It was really impressive.
Thank you so much.
Masterclass in that, really, really good. But we've still about 5 minutes or so. I'll throw it open to the floor if anybody's any questions. Please put them in the public chat or the Q&A. But maybe just to start off, and I think you hinted at it there.
Mm-hmm.
In terms of setting participants up and getting them orientated to the games and so on, it took 5-10 minutes, and there was some technical challenges around that. If we were to implement this in the home in some sort of blended approach,
yes,
what sort of strategies or what sort of support might patients need for that?
I think that's a really good question. I think we need to think about, I guess, the training of virtual reality. So participants in my trial, they had a little bit of a training testing session, but they were very dependent on me being there to help them with usability and their rehabilitation. So think about their training, how we can set up their home perhaps to be safe for virtual reality. So sort of safety considerations, so education, safety considerations, but also need to think about the software as well. Think about how we're able to communicate their, I guess, their scores or their movement data to a clinician or physiotherapist, because I think that communication between both is really important for successful long-term rehabilitation. So
Absolutely, and that raises challenges around the communication of, is it medical information that you're communicating, or are you just chatting to someone on a WhatsApp, for example? But um,
exactly.
I, that implementation piece is really, really important, because even though the patients like the games that were developed were excellent, but when you get to the stage where we have to do it in the home without that sort of wraparound support, I think as people who are interested in VR and people who want to get it into the home and want to implement it, I think there's a gap there that we have to think about, But well, that was really excellent. Thank you so much. Are there any questions from the audience, or have we're all too shy?
That's okay.
In Q&A, we have a question, which I can't see.
I can see it.
Can you see it? I can't see it.
Yeah. You're welcome, Sarah. Did you have any quantitative data collection in the game? Yes. How did you make sure that the participants were not compensating for better quality rehab? Yes. So that's something that definitely came up from my focus groups was, how do we ensure they're actually doing the movement that we want to do? So there were, it's not scope for my project because, I kind of ran out of time. There was, I guess, different requirements that were more essential. So I sort of just focused on the score feedback. So the score systems were saved within the game. So their high scores were saved, and that was quite a nice visual tool. But in terms of, is it really reflective of the movement that they've done? That's something I'll need to refine in future. So it helped that I was there, but as Joe was saying, when it comes to implementing VR at home, we'll need to think about the sort of different parameters we can make within the game to ensure that they do the movement that we want to do. So scope for future work. I hope that answers your question.
And we have a question here from David, one of our colleagues. He says, excellent presentation. How would you suggest we reconcile the feedback from patients and clinicians, where one wants daily activities, probably from a clinician who has unrealistic expectations of patients, and the other prefers more abstract games? I think it's about setting realistic parameters for the patient and realistic goals and so on. You mentioned that earlier. But was there any tensions between the clinicians and the patients in terms of their expectations?
No, I think it helped that I conducted the focus group separately, so there was no sort of influence upon one or the other. It was just they mostly agreed upon the targets, the considerations for development. But when it came to those game ideas, that's definitely where it differed. So I think for me as a developer, as a researcher, I need to think about who's actually going to use these games, and it's people with MS. So they were my priority when it came to the decision making. But that is not to say that I disregarded the clinicians. So we need to think about the functional activities that they want to see. So can we make those functional activities disguised within these more abstract ideas? So that's what I kind of try to do with these pilot games.
Excellent. And Sarah asks, how did you score the participants?
So they just so it was just within the games itself. So they were scored based on the mechanics of the game. So for Catch a Falling Star, how many stars were they able to grasp? How many piano keys did they hit during a sequence as well for the piano game? And then Whack-A-Mole, how many poor little moles did you whack? There were some bonus scoring within the Whack-A-Mole game. That was actually quite a nice incentive, having something that gave them more points. But that's the scoring I'm talking about, is how many successful actions did you get?
And what sort of future developments have you got in mind for the games?
I'd love to expand upon them a bit further and think about how we can make the progression, I guess, how we're able to progress people that found perhaps these games a little bit easier. How can we make it a little bit more challenging? So adding different, variety of games. But also there's been some really interesting work coming from my PhD with a PhD student here, looking about, how can we measure this kinematic data, this movement data within virtual reality-based headsets. So
maybe some sort of sensor wearing or
could be, yeah. So how can we, realistically, how can we measure kinematic analysis at home?
Very good. And Sarah has another question, which maybe the last one. How did you tackle the question about accuracy of headset tracking versus gold standard motion capture tracking. Excuse me.
No, that's fine. So I think with Oculus Quest, I think I was quite lucky because I noticed that the hand tracking improved during my development process. So I think the hand tracking offered within the Oculus Quest headset is actually pretty good. So I was quite lucky that I didn't need to, I guess, sell it. It was really quite good tracking. And you got to think about the accessibility. This headset is commercially available as well. So I think if it's still able to offer quite precise hand tracking, I don't think we need to worry about the sort of gold standard that you were saying, sort of more high tech, more expensive equipment to track upper limb movement. I think the hand tracking we've got right now is quite good, and it's improving within these commercial devices.
Okay, so excuse me, I've lost my voice.
You're fine.
Thank you so much, Amy. That was an excellent presentation. Just to say, it will be available on the website within the next few days for all participants, and a link will be sent out, I think. But again, everyone again is expressing their thanks, and I just like to express my thanks while my voice is still here. So thank you so much.
Thank you all.
We'll finish off with that. Thanks a million, anyway.
Thank you.
And thanks everyone for attending.